patent ductus arteriosus. All right, in utero, the blood circulation is different for a fetus compared to adult life. One of the differences is that most of the blood bypasses the lungs and goes directly into the aorta during fetal development. So there's a connection between the pulmonary artery and the aorta. So when blood comes into the pulmonary artery and tries to flow to the lungs, the pulmonary vessels are really constricted. Not a whole lot of blood gets to the lungs. There's enough blood flowing to the lungs to keep the lungs developing. But as far as gas exchange does not take place in the lungs. It takes place at the placenta of the mother. So 90% of that blood doesn't go to the lungs, but instead it gets shunted past the lungs and into the aorta, and that's through the ductus arteriosus. And then once birth occurs, then that's no longer the pathway of least resistance. The pathway of least resistance becomes the pulmonary vessels going to the lungs. So the blood happily gets to the lungs and really doesn't want to go into the ductus to get to the aorta. So since there isn't much blood flowing through the ductus after birth, it just kind of slowly closes itself off, and usually by 3 days after birth, it's closed off, and there's no blood flowing through. All right, so let's see what the notes say. Normal fetal structure allowing blood to bypass circulation to the lungs is defining the ductus arteriosus. Before birth, the aorta and the pulmonary artery are connected by the ductus arteriosus. Within minutes or days after birth, the ductus arteriosus closes, which is a normal change. However, in some babies, the ductus arteriosus remains open or patent, allowing oxygenated blood from the aorta to flow into the pulmonary arteries. So let's talk about that a little bit. This picture A shows how there's just a ligament now instead of a ductus arteriosus connecting the pulmonary artery to the aorta. However, if it stays patent or open, after birth, the pressure in the aorta is higher than pressure in pulmonary circulation. Remember, the pulmonary vessels have very low pressure compared to the aorta, systemic circulation, high pressure. So after birth, when you've got the high pressure in the aorta and the low pressure in the pulmonary artery, blood will start shunting from the aorta back into the pulmonary artery. Does that make sense? Blood's going to flow from high pressure to low pressure if that ductus stays open and doesn't close. So if it doesn't close like it's supposed to, you've got the high pressure of blood in the aorta will push blood through the ductus arteriosus and back into pulmonary circulation. So the blood will flow, I guess you could say backwards.
Because it goes back to the lungs, correct?
Yes.
It's going to the pulmonary artery, then back to the lung.
Mm-hmm.
To pick up nothing because it's already oxygenated.
Yeah, so think about it. The blood will flow normally to the lungs, picks up oxygen, comes back to the left heart, goes into the aorta, and then falls back through the ductus arteriosus to go to the lungs again. So the lungs end up getting a lot more blood flow than they're used to.
Question.
Okay.
When it's pumping blood into pulmonary arteries, since it's still open, can deoxygenated blood also go into the aorta?
Not normally, but when we talk about pulmonary hypertension, we'll talk about that happening.
Oh, because greater to lower. Oh,
Mm-hmm.
that makes sense.
So this shows the blood in the aorta being pushed back into the pulmonary circulation. Does this help you understand it? It says, patent ductus arteriosus is failure of the ductus arteriosus to close. After birth, as the pulmonary vascular resistance falls, the pressure in the aorta is greater than the pressure in the pulmonary artery. The flow of blood changes from the aorta to the lungs. Is that wording help you, or
Yeah,
you're okay
that
with it?
explained it.
I have a question. What are the problems that occur with that? The blood-forming action
You can get pulmonary edema from it because there's too much blood flowing in the pulmonary circulation. So pulmonary artery pressures will become higher than normal. And if it continues, then you start getting a remodeling of the pulmonary vasculature. It starts to thicken, I guess, from so much blood flow. You end up with a more permanent type of pulmonary hypertension. Yeah. But it's expected when the babies are premature. So it says the delay in spontaneous closure of the ductus is inversely related to the gestational age. So really, really premature, high PDA chances. So by 32 weeks of gestation, only about 20% of the ducti don't close. But if they're less than 28 weeks, about 60% of the premature infants will have a patent ductus arteriosus. So it says pathophysiology tells us that there's left to right shunting. Again, that's high aortic pressure pushing blood into the low pulmonary pressure. So it causes an increased pulmonary blood flow, which leads to pulmonary hypertension and pulmonary edema. So it's diagnosed with an echocardiogram. So using ultrasound, they can see that the ductus is patent and blood is flowing into the pulmonary vessels. Sometimes they'll do nothing and they'll just wait a few days to see if it'll close on its own. There's a couple things that can help it close, and one of them is Advil, believe it or not. So giving the babies ibuprofen will help it to close. Another drug given is Indomethacin. Indomethacin will reduce prostaglandin levels, which will cause the PDA to close. So prostaglandin is a chemical that's circulating in the blood in premature babies, and it keeps the ductus arteriosus open. So by the time babies are 40 weeks gestation, there's very little prostaglandin circulating. So once they're born, there's nothing keeping that ductus open, and then it just closes on its own. Preemies, they've got a lot of this prostaglandin going on, keeping the ductus open. So you can block that prostaglandin by giving indomethacin or by giving ibuprofen. So does that make sense? Mm-hmm. So maybe in your notes you can write like prostaglandin keeps, like circulates in fetal blood. So prostaglandin circulates in fetal blood, keeps the ductus arteriosus open, or DA for short. Keeps the ductus arteriosus open. All right, so repairing it, it's typically a banding procedure where they'll make an incision in the thorax between the ribs and get to it and put a band around it to help it close. And I'm noticing it's not even listed here. Coil occlusion. Don't know what that is. So The typical procedure is a banding procedure around the ductus arteriosus, and that'll close it off. Looks like we got some questions here. Number 1, normal transition to extrauterine life depends on the pulmonary vascular system, A, remaining in a steady state of balance with the hepatic blood flow. Boy, that sounds like a bunch of beeswax. B, changing from a low pulmonary vascular resistance to a high pulmonary vascular resistance. That's not supposed to happen. C, changing from high pulmonary vascular resistance to a low pulmonary vascular resistance. Yes. Correct. So the correct answer is C.
What is extrauterine? What is that?
After birth?
After birth?
Yeah. So intrauterine would be the fetus is still in the uterus.
Got it.
And then once they're born, you say extrauterine.
That's funny.
Which of the following affects pulmonary vascular resistance?
Change, well, all of the above. Yeah, I'll do.
Yes. So the answer is all of the above for that one. With a low PaO2 in the blood, the response of pulmonary vessels is to constrict. Acidosis, whether it's an acidotic pH or a high CO2 causing acidosis, again, the vessels will constrict. Which medication can be given to an infant to facilitate closure of a patent ductus arteriosus?
B and C.
B and C.
Yes, very good. B, Indomethacin, and C, ibuprofen. So that's what, letter E?
Letter E, yeah.
Pulmonary edema in premature infants is a symptom of which complication?
PDA.
Yeah, it's the only one you learned so far.
Are the other ones also different diseases? I know ROP is.
What is wrong?
Retinopathy?
Prematurity, but not other.
Very good. So no, it's not a complication of that. Blood flows from where to where in a premature neonate with a patent ductus arteriosus? Aorta to pulmonary artery, or
no,
pulmonary artery to aorta?
Because you said,
In the prenatal.
oh, okay, they're already out. Yeah,
They're
so
already out.
It'd be A, yeah. Yeah.
So the correct letter is A, aorta.
Because I was thinking in the womb. Because like in the
Oh,
womb,
right.
then
It does
it'd be
go.
the other way around.
Yeah.
Yeah.
Okay, now we'll talk about persistent pulmonary hypertension of the newborn. So I was describing to you a fetus in utero. Blood doesn't need to go to the lungs because it's not going to get any oxygen or give up any carbon dioxide there. You just have a little bit of blood flowing into the pulmonary vessels. So those pulmonary vessels are constricted and very little blood flows there. Now, at the time of birth, either during delivery or right after birth, if there's a situation that causes oxygen level to be low, then the pulmonary vessels reconstrict and they stay constricted. And whatever you do, it's very hard to get them to dilate and relax again. So that's what persistent pulmonary hypertension of the newborn is, PPHN. So you see this quite a bit in the NICU. PPHN is found in infants that are term or post-term. Do you know what that means? You say the infant is term?
40 weeks.
Yes, 38 to 40 weeks when they're born. Like full-term gestation, instead of spelling all of that out, they're just saying term. So full-term or 38 to 40 weeks of gestation. So it explains it in the next bullet. It says premature infants don't have smooth muscle around their pulmonary vessels, so they can't develop PPHN. So does it happen in preemies? No. It does happen in full-term babies, but not in preemies. It is brought on by anything that causes hypoxemia in a newborn. And then it lists some different things. Meconium we haven't talked about yet. Perinatal asphyxia would be either the placenta gets separated from the uterus, the cord gets wrapped around the neck of the fetus in utero.
I've heard of that. I've heard of that.
Yeah, so lack of oxygen around the time of delivery. That's going to lead to hypoxemia. A congenital diaphragmatic hernia we'll talk about next week. What can happen is when during fetal development, very early stages, like 8th week I think of development, instead of the diaphragm forming and closing, it stays separated and the abdominal contents start growing inside the thorax. And it completely squishes the lung and the lung doesn't grow. So that's congenital diaphragmatic hernia, where all the intestines are up in the thorax. That'll cause PPHN. Sepsis, do you know what sepsis is?
Massive infection in the body.
Yes. And then RDS,
Respiratory distress syndrome.
yes, which we usually don't see when they're term because
They've gotten help for that already.
they already make their surfactant. Yeah, I don't know why that's listed there.
Meconium aspiration.
Oh, meconium aspiration is fetal poop that gets into the lungs.
How, is that common?
Explain that.
I think 2% of
Oh,
all.
okay. I was like, that sounds horrible.
No, what's the percent?
Meconium aspiration, it's when the poop from the fetus gets into their lungs.
Yeah, and you said 92%.
No, only 2% of
92% of babies. It's a hygiene.
All right, so a period of hypoxia around the time of birth causes the pulmonary vessels to constrict. Because remember, that's their response to low oxygen, is they constrict. This causes pulmonary hypertension. And once those pulmonary vessels are tight, now blood can't flow to the lungs very easily. So you've got blood flowing from right to left, meaning it goes from the pulmonary artery and pushes through the ductus arteriosus and gets into the aorta. See how that's the reverse of what we just talked about with PDA? Now we've got the opposite happening. We get pulmonary hypertension, the blood can't get to the lungs, so it exits out the ductus arteriosus and gets to the aorta instead. Do you know why it's called right to left?
Right to left shunting.
Because the right heart
'Cause
is
it's-
supposed to push it into the lungs, but it can't go, so it goes straight into where the left lung is supposed to push.
Yes.
into the lung.
Yeah, very well stated. So right to left shunting.
Wait, say
All
that
right.
again? I
Yeah,
didn't-
what does right to left shunting mean?
Yeah, what's the answer? I don't know.
Do you want to repeat it?
The right side of the heart is supposed to pump the blood to the lungs, but since it can't get to the lungs, it's pushing it straight through into where, the left side is supposed to pump to the left. Yeah.
All right, so how do you figure out that the infant has this right to left shunting or PPHN? The heart will look normal. There's going to be severe hypoxemia. Why does it have these two numbers? I guess it's supposed to be a range, 37 to 45
On 100%.
on 100%. There will be evidence of right to left ductal shunt. And now, how do we figure that out? We're going to put a pulse oximeter on the right hand and below the umbilical cord. So on the legs, basically. If there's a difference of 20 millimeters mercury or more, then that tells us we've got blood being shunted through the ductus arteriosus. I think there's more slides to give you pictures of that happening. Okay, I think this helps.
So it's for
All right, so let me try to explain why we could put a pulse oximeter on the right hand and then put one on one of the feet, and why we might see a difference in oxygen content. So when there is blood flowing from the pulmonary artery into the aorta, it happens towards the end of the arch of the aorta. So it doesn't affect blood that comes out of the left ventricle and goes into the aorta right away. It affects the blood on the other two vessels. Well, this first vessel that branches off of the aorta is the Brachiocephalic Artery, and that's the vessel that feeds the right arm. So it's located before the deoxygenated blood enters. So we're going to get a true view of how the lungs are doing when they oxygenate. But then we've got this blood mixing from the right, coming out of the right ventricle, going into the pulmonary artery, can't get to the lungs, so it pushes into the aorta through the ductus arteriosus. And now we've got mixed arterial and venous blood in the aorta. So it tells you mixed oxygenated and deoxygenated blood enter the left common carotid artery, which is here. And then you've got shunted. What is the name of this one? This is the left common carotid. What is this one?
the right common carotid.
Is that not the brachiocephalic? That one?
No, the
Brachiocephalic, and then what?
There should be two brachiocephalics, right? One for left, one for the right.
Brachiocephalic one.
I do this every single year. I cannot remember these. And I memorize it, and say, okay, I've got it. And then I try to teach it, and every year I forget the name of these two. So the point is, everything else gets mixed venous blood except for the right arm. So that's why you put the pulse ox on the right arm. It's going to be called pre-ductal O2 saturation. So when you have the pulse oximeter on the right arm, it's called pre-ductal O2 saturation. It's before that shunted blood gets mixed in. Question?
Yes. Okay, so you said earlier that, is it a protein that helps, what keeps that open in the blood?
Oh, prostaglandin.
Thank you. Okay, so at this point, the reason why it's still open is because of the pressure, because they're post-term or term, right? So it should be depleting. So the pressure is what's keeping it
Yeah.
open.
Yeah, the high pressure pushes it open and keeps it open. So there's preductal and postductal, and I thought there was a picture that shows or talks about the head of the baby. To measure O2 sats in the head, sometimes it'll get some freshly oxygenated blood and some mixed venous blood. So you can't really do O2 sats on the head anywhere because that won't really reflect the pre and the post. So for pre and post, you've got your right arm, and then below the umbilical cord, or the legs actually, umbilical stump I should say. All right, here's a question. If there is indeed persistent pulmonary hypertension occurring in a full-term newborn, and deoxygenated blood flow is being shunted across the ductus arteriosus into the aorta, would you expect the right arm to have a higher PaO2 or a lower PaO2 than the umbilical artery?
Higher? Because higher sat means higher O2.
Yes. So the correct answer is A. You'd have a higher PaO2 in the right arm. Do you understand why?
Yes.
It's pre-ductal or before the shunted blood is coming into the aorta. So how do we diagnose PPHN? Is that a question or is it giving you the
telling
answer?
us. Yeah, it's
Okay.
giving us an answer.
So an echocardiogram will detect the flow of blood across the ductus arteriosus. We can get a pre and a post-ductal PaO2 or O2 saturation. Do you want to write SpO2 on your notes? Because it can be a blood gas that you draw from the right radial artery, and then you'll take arterial sample from the umbilical. Hopefully there's an A line in the umbilical artery. Or you do pulse ox. So if there's a difference of 20 millimeters of mercury in the PaO2, what is the percent saturation difference? So 180. You can put down 10% for now, and I'm going to have to double check with you, or for you.
10% under.
A 10% difference in O2 sat. So it's telling us what the difference in the PaO2 should be, but how does that correlate with O2 saturation? You can do a hyperoxia test where you deliver 100% to the newborn for about 10 to 15 minutes. And remember how pulmonary vessels constrict when there's hypoxemia or hypoxia? Well, if you improve oxygenation, they should relax and dilate. So if you hyperoxygenate for 10 to 15 minutes, get a lot of oxygen in the body, the pulmonary vessels will relax, and you'll see the O2 sats kind of equalize and become the same, because blood will stop shunting and start going to the lungs to pick up oxygen. All right, does that make sense? Mm-hmm. Increase the oxygen, pulmonary vessels dilate. O2 sats equalize. All right, so that's theory now, because it used to be done, and now it's considered too dangerous to do that to infants, to put them on 100%. The concern is even 10 to 15 minutes of 100% oxygen can cause oxidative stress to the lung tissue. But the theory still applies, and I think it still shows up on your national exam. So 100%, just remember the connection. Increase O2, pulmonary vessels dilate, O2 stats improve. If that happens, that means that it is shunting, and you do have pulmonary hypertension. Or you could do the hyperoxia hyperventilation test, where you hyperventilate, you get the CO2s down real low, oxygen up, and of course, once you do that, the pulmonary vessels will dilate. Because alkalosis causes the pulmonary vessels to relax. High oxygen causes the pulmonary vessels to relax. So if you hyperventilate, hyperoxygenate, and all of a sudden your O2 stats become the same in your right arm and your leg, it's like, we did have some pulmonary hypertension here. So that's how it's diagnosed. It's usually the first two, where you've got your pre and post ductals showing different sats, and an echocardiogram shows flow across the ductus. The hyperoxia test and the hyperventilation test are more for theory than actual application in the NICU.
For the hyperventilation, are they intubating?
Yes. Yeah, they would have to be intubated on the ventilator. All right, so how do we treat PPHN? It says to treat the underlying causes. So if it's sepsis, then antibiotics. If it's lack of oxygen, we give oxygen. To support ventilation and oxygenation, it requires intubation and mechanical ventilation. High frequency ventilation will oxygenate and protect the lung from barotrauma. So it's, baby has PPHN, having a hard time oxygenating. Instead of using high PEEP, high FiO2 on our conventional ventilator, it's better to put them on high frequency ventilation. We can maintain good O2 sats like that and not destroy the lung tissue so much. So, high frequency ventilation, that's another lecture coming up in a few weeks. Nitric oxide is great because it directly works on the pulmonary vessels and dilates them. And you deliver the nitric oxide via the ventilator circuit, so it just becomes part of the air that the infant breathes in. They breathe it in, it goes to the alveoli and crosses over and gets into the capillaries and immediately dilates those pulmonary vessels. So within minutes of having the baby on nitric oxide, their O2 sats improve. So getting into detail on nitric oxide, that's another lecture coming up. And so is ECMO. We'll talk about that later also.
I hear that so much. ECMO in the hospital. I hear that a lot. That word.
What is it referring to, do you know?
They say, oh, I'm not really sure. That's
It's
fine.
like a, isn't it like a bypass? Kind of, like they're bypassing they're feeding oxygen to the extremities in the body, and it's bypassing the heart and lungs. Is it filtering the blood?
Yeah, it looks kind of like a dialysis circuit where the blood is taken out of the body, it's oxygenated, and then put back in with the
Now I
oxygen.
remember, yeah. I remember that for sure.
Yeah, so if you've seen open heart surgery and there's a bypass machine that takes the blood from the body, oxygenates it and puts it back in the body during the heart surgery.
Yeah.
Yeah, so that's pretty much what ECMO is, but it's not during surgery, it's just, you know, the baby's laying in the bed and they oxygenate with ECMO.
Is their chest cavity still open though? Or they can do without?
It's just putting catheters into the jugular vein and sometimes into the carotid artery. Take it out of the vein, put it into the artery already oxygenated.
It's so interesting.
Yeah, and Memorial Regional has become the go-to hospital for adult ECMO patients. So what's been happening is there's young patients in area hospitals that can't be oxygenated. They go into ARDS for one reason or another. Last year when we were rounding, it was a lot of